This webinar on recent advances in COVID management by IMA Hyderabad City in association with UNICEF. I welcome Dr. Gattu Srinivasulu, President IMA Hyderabad City, and warm welcome to Dr. Vijayendra Reddy, President IMA Telangana State, Dr. Pratap Reddy, Past President IMA Telangana State, Dr. Sanjeev Singh Yadav, Honorary Secretary IMA Telangana State, Dr. Dilip Banshali, Senior Member and Editor IMA Newsletter, IMA Hyderabad City Branch, Dr. Mohan Gupta, Dr. Rajendra Kumar Yadav, Past President and President-elect. Welcome to today's moderator, Dr. R.S.V. Sri Krishna, Consultant UNICEF, and a warm welcome to our panelist today, Dr. Rajiv Gar, Additional Professor, Anesthesiologist, AIMS, Dr. Vinay Shekhar, Professor and HOD, Gandhi Medical College, Dr. Srinivas Samavedam, Senior Intensivist, Virinchi Hospital, and Dr. Srirang Apkari, Member Scientific Committee, IMA Hyderabad City Branch. I welcome you all. Now hand over the proceedings to our President, Dr. Gattu Srinivasulu. Please take over, sir.
Thank you, Dr. BN. Sagam pani meeru cheesinatte welcome address mottham meere cheppesi. I too, very good afternoon to all my dear members of IMA Hyderabad City Branch and all the senior doctors, Dr. Vijayendra Reddy, Dr. Pratap Reddy, Dr. Sanjeev Singh Yadav, and Dr. Dilip Banshali, and also Dr. Sri Krishna, RSC, a consultant from UNICEF as moderator. Panelists are Dr. Rakesh Gar, Dr. Vinay Shekhar, Dr. Srinivas Samavedam, and Srirang is our coordinator. We being the host for today's meeting, we invite all of you to this meeting. Thanks for coming and wishing us. Hope the CMV will be very clear many doubts about COVID-19 management, and we are very much eager to organize virtual CMEs regularly, and we are regularly we are planning to conduct virtual CME meetings in the month of July, August, September, and a small thing, we were unable to, the members of IMA Hyderabad City Branch, we were to conduct the MC meetings due to Corona pandemic, and we are planning to conduct the MC meetings also with as virtual meeting from July month. Once again, I welcome you all, and I personally, whether time may permit me to thank Dr. Sri Krishna or not, at this juncture I am thanking Dr. Sri Krishna for giving us this opportunity and making the CME in progress. He is actually a friend of Dr. Vijayendra Reddy. It was made available, this CME program, with UNICEF. He is a consultant from UNICEF, Dr. Sri Krishna RSV. He is a moderator, and I requested Dr. Vijayendra Reddy, our President, IMA Telangana State, to be as a chief guest and speak a few words about the CME and COVID management, 19 management.
Thank you, Dr. Gattu Srinivasulu. Am I audible now to everyone?
Yes, sir.
Yeah. At the outset, let me
yes, sir.
The city IMA branch as well as the UNICEF Hyderabad chapter for conducting this beautiful webinar. The topic today is the recent advances in the management of COVID. It's a very useful topic in the present day context, and there are so many seekers and enthusiasts participating in this conference, and because we have expert panelists, people who have got real experience in treating COVID patients, and it will act as a first-hand information to all of us. And I congratulate Dr. Gattu Srinivasulu and Dr. B.N. Reddy for arranging this webinar, and it will be very useful for everyone. And I make use this conference. Thank you so much for involving. Thank you once again.
Thank you, sir. Thank you for being with us. I request Dr. Pratap Reddy, immediate past president of IMA Telangana State. Please, a few words, sir.
Thank you very much, Dr. Gattu. Can you hear me?
Yeah, sir.
Thank you very much, Dr. Gattu and Dr. B.N. Reddy and all the senior members of the IMA participating. And it is a feather in the cap of Hyderabad City Branch for having not only taken this excellent initiative, that too with collaboration with the UNICEF. It's an excellent program. I only wish that there is a lot of confusion in the society of the treatment of COVID. There are no finality to answers. There is no answer to so many things. So I think we as IMA should be able to give a protocol for the situation, at least in our state. So IMA has always stood by academics, always stood by the society. With these few words, I can only tell, let us go forward to support the society, guide the government, and we save ourselves. It is very important. Thank you very much.
Thank you, sir. I request Dr. Sanjay Singh Yadav, our past president and secretary IMA Hyderabad, Telangana State. Please, a few words, sir.
Good afternoon, everybody. As everybody is saying, it's a nice initiative. Definitely, it helps in progressing the medical field through one way or other. Although we are not in touch with each other, but this eye contact through a video is something which is very different. And I congratulate the City Branch for doing it. It is not just the City Branch. From a long time, we have been contemplating in doing this, but there are some issues which we have to take care. Regarding COVID-19 in Hyderabad, per se, the situation is really very bad. Receiving just now from at least 35 traders union, they have made from Sunday to next Sunday a close down of all their activities, irrespective of the economic slowdown. So it is time that we gear up to this situation. And if there is any need, we have addressed the traders also. Today afternoon, I was addressing the traders through Zoom meeting. That if there is any need, the only problem is a lot of complaints regarding corporate sector people charging more, asking for deposits. Even the press people are calling me from the morning that some hospitals are asking more than 3 lakh rupees. This is something which IMA has to talk to those people and take care of it. I hope things become better. Good luck for this, and I think this must be a continuous process. Many other things must follow after this. Thank you very much.
Thank you, Sanju Bhaiya. Few words from Dr. Dilip Banshali. Sir.
Good afternoon, everybody. A good initiative from Hyderabad City Branch to start this. The need of the hour. Yes, we are guided. Rightly said, we should have a guideline. And more than that, we should identify some places now for our members also. If somebody is getting COVID from our fraternity, there should be some provisions in all these corporates. They should have preference. Of course, we have talked all to the corporate sector. They have agreed to give concession and preference to all our members. So that's one thing which is very important. And we should also think it should be have some quarantine center in Ireland. That of course we can talk later. Wish everybody, the panelists, all the best, and let us start. Thank you.
Now, I request Dr. Srirang Apkari, our branch scientific committee member, to be a coordinator and continue the proceeding.
Yeah, Dr. Sri Krishna, hand over to Dr. Sri Krishna, RSV.
Oh.
He is the moderator.
Oh, Acha is coordinator. Yeah, okay.
A very warm welcome to all the IMA members of Hyderabad as well as the state of Telangana. Warm greetings on behalf of UNICEF. We have here Dr. Sanjeev Upadhyay. He is the health specialist of UNICEF Hyderabad field office, and he oversees the operations under the entire domain of health. Request Dr. Sanjeev to please give his inaugural remarks on behalf of UNICEF.
So good afternoon, everyone. So on behalf of UNICEF, I welcome all IMA members to this very interesting webinar, which is on the clinical management of COVID-19. almost 150 people logged in now. And I mean, that itself shows the interest of people in this topic. And it is very timely action because now government is allowing private sector to open and to treat COVID-19 patients. I'll not take time. I would just like to thank Dr. Rakesh Garg, who's from All India Institute of Medical Sciences, Dr. Srirang Akbari, who's a consultant at Omni Hospital, Dr. Vinay Shekhar, as well as Dr. Srinivas Samvedam for their availability to be a resource person for this workshop. UNICEF is always in forefront in supporting states in implementing programs and policies which are there to help mother and children, and also in times of emergencies. I met many of you at different platforms, different fora, and I fondly remember those things. But with this COVID-19, probably we don't have luxury to meet people in person. This is the only way we meet each other. So without much ado, I request Dr. Sri Krishna to take it forward. And I assure you that this is just a beginning. UNICEF will remain committed and open to facilitate high-level technical meetings, inviting people, resource persons from all over the country, and also some of the global experts. So over to you, Dr. Sri Krishna. Thank you, everyone.
Thank you, Dr. Sanjeev. So we're all set, and it's a very warm afternoon. And before we start, Dr. Narendra Reddy, sir.
Yeah, Vinay Shekhar is waiting for become panelist, I think.
Okay.
Vinay Shekhar. I am doing now.
Yeah, you can do that, sir.
Yeah,
at the outset, let me thank the entire team of IMA Hyderabad as well as the state for putting this together. And it's probably the best panelists I have seen in a very, very long time. We often hear sessions on COVID, which are picked up primarily from research or what we hear. But this time we are talking to people who are literally on the field, and we are here to understand the recent advances in COVID management and also share their experiences. I've made sure that the session is a highly interactive one. We'll start with what is the current status. We'll go through what are the recent advances, and I assure you it will be a highly enriching and informative session. Let me start with the presentation. I'm sorry we're not able to go on live on YouTube, but I'll try to sort it out in due course of time. All right, so here we are on the recent advances in COVID management, a wonderful opportunity by IMA Hyderabad City Branch. At the outset, let me present a few points to ponder. As we are talking of COVID management, we know this is a new disease, a few months old, literally. We all would have seen diseases of decades old, and we're trying to treat them. And here we are with a disease which has just literally in the infancy period. We know very little. Seriously, there is not much that we would have understood from the experience in China or the other countries which started before us. But that's not the problem. The problem is that we are getting to know a lot more. And this will happen in due course of time. As the cases increase, as more and more get affected, we understand different facets of the disease, and that gives us more information. But this information needs to be processed, and we need to use it for management. We have been used to using evidence-based information for all our management decisions, and we continue to do that even here. We need to be rational. We need to be making decisions which are based on evidence, based on science. But at the same time, we need to be pragmatic. We need to prioritize. We are in an unprecedented situation, and these extraordinary circumstances need us to think beyond the box, require us to think of the entire society as a whole, Also, for the first time, I would say, think of our own selves. Think of our safety so that we are able to do more justice to people around us. And in this process of getting to know more information, making evidence-based decisions, and then trying to prioritize our actions, we need to learn. We need to learn, review, and we need to adapt to what has been the new change and what is it that works. Amidst all these, apart from all these 6 points, all of which are very, very important, let me put up the bottom line. The bottom line is that at the end of the day, we need to follow whatever is the government of India or government of Telangana's policy or guidelines. That is what is going to make us safe, both at the legal front as well as when you are implementing. And we all know that there is a team of experts who are working on this at various levels, and they are contributing their expertise to make guidelines for us who are the frontline warriors to implement. So with this background, let me quickly take you through the scheme of presentation. So we'll be starting with a small global perspective on where we stand as of now. Then we're talking specifically on COVID management. So the management, as we all know, starts with diagnosis, which is mainly testing. And then we look at the spectrum of COVID management, the mild cases, the moderate cases, and the severe cases. And we'll look at current recommendations, recent advances, and I promise we'll all have a take-home message at the end of the session. Let me give you the global perspective, and what better than government of US recommendations or whatever US is doing currently. Let me pick up the country with the highest number of cases and the one which frames all the policies which we all see. So this is the web page of the White House as well as the CDC, and this is how it looks like. They give us information which is up to date, and as on yesterday night, COVID continues to be an emerging, rapidly evolving situation, and the NIH has COVID treatment guidelines. What is new? As on yesterday night, this is what is new. Let me take you over the next 3 minutes into what is US doing right now. The recent updates from US are, this very important table has emerged, which is detailing the potential antiviral agents under evaluation for treatment of COVID-19. The first one, let me tell you about azithromycin. This is something we've been using for a very long time for other illnesses, other infections, and the clinical data to date has been of azithromycin studied for treatment of COVID-19 only in combination with hydroxychloroquine. And the panel currently recommends against the use of hydroxychloroquine plus azithromycin. This is the end recommendation. We have some more which are coming up. What about chloroquine? Lot of information on chloroquine, again an old drug, put up in a new bottle, I would say, and primarily used for malaria and amoebiasis, and now being put up as a management option for COVID. And what has been the interpretation from the studies and the evidence which we have? Despite the small number of patients enrolled, the study continues to raise a concern about increased risk of mortality when a high dose chloroquine is administered, especially in combination. That's the bottom line for chloroquine. What about hydroxychloroquine? Again, lot of information. There were multicentric trials primarily based out of New York City, and even they have shown no beneficial effect of hydroxychloroquine plus azithromycin for treatment of COVID. So the panel recommends against the use of chloroquine or hydroxychloroquine for the treatment of COVID-19, except in the scenario of a clinical trial. And other antiviral drugs, the panel recommends against using the following drugs except in a clinical trial. So the rating of recommendation and the evidence is also given, all of this as of yesterday night. So at the end of it, what does government of US say? The summary recommendation is there are no FDA approved drugs for treatment of COVID-19. Very clearly in bold letters, it spells out the latest update. Although there is a small footnote. The footnote says, although remdesivir, an investigational antiviral drug, is available, but only through a FDA emergency authorization. And it continues to state, that definitive clinical trial data is needed to identify safe and effective treatments for COVID-19. Having mentioned about remdesivir, let us just look at what government of US and the CDC mention about this drug. It is very clearly recommended for hospitalized patients with severe COVID. So the panel recommends this as an investigational antiviral agent for the treatment of COVID-19 in hospitalized patients, specifically with a SpO2 less than 94% or those who require supplemental oxygen. And the panel recommends this for the treatment in patients who are on mechanical ventilation or on ECMO. Recommendation for the duration of therapy, 5 days of treatment, and the recommendation for those who are on ventilator and have not shown adequate improvement even after 5 days, they don't have sufficient data on the optimal duration. Max it can take up to 10 days. So this is what is on the CDC and the government of US national web page. What is the recommendation for mild to moderate cases? Again, very clearly spelled out that there is insufficient data for the panel to recommend for or against remdesivir for treatment of patients with mild or moderate COVID-19. A last update has been on the multi-system inflammatory syndrome in children. They've noticed that some of the children have started to have Kawasaki disease-like features, but a slightly different presentation. It occurs in an older child. There is a rapid cardiac involvement, which is not very typical of Kawasaki, at least in terms of the progression. Association of shock, a multi-organ dysfunction, macrophage and activation syndrome, and the need of adjunctive steroids. So this has been the presentation of this MISC, or the multi-system inflammatory syndrome in children. And at presentation, few of them are PCR positive, but most of them will have a detectable antibody. What this has led to as a conjecture, I would say, or an inference, is that probably this MISC is a post-infectious inflammatory phenomenon rather than a direct viral process, because of its course, the fact that you are seeing PCR positive in a few but antibodies in almost all of them, and the difference between the classical Kawasaki and this. Treatment, supportive care continues to be the mainstay of treatment. So that has been the update on COVID from the West. And I picked up one government. I also had a look at some of them in Europe and others. But now let's come back to our own country, our own state, and look at what are the latest updates. And as I promised, we look at information which has come from reliable sources and which has some implication for our practice. At this point, I invite Dr. Rakesh Garg, who is the additional professor anesthesiology at All India Institute of Medical Sciences, New Delhi. And this is where all the action is happening. This is where these guidelines are all coming from. Dr. Rakesh, we'd like to hear more from you, especially on the aspect of testing. Please tell us what is the current ICMR recommendation. As we all sit in Hyderabad and the state of Telangana, we want to know what does AIMS and ICMR tell us on who to test, one. Second, please tell us what is this new additional strategy for COVID-19, and then tell us all about other tests and other investigations that might give us a little clue into what this is. Over to you, sir.
All right, thank you so much, and thank you IMA Hyderabad and UNICEF for organizing such a nice program, which will be useful to all of us, in fact, for a learning exposure. Now, I think testing has been the forefront for the COVID management since beginning, and there have been many changes from the beginning until date. But having said that, as you asked, which is the changes which has happened for the diagnostic modalities of the COVID-19, the RT-PCR remains the gold standard. There is no confusion about it. And the real-time RT-PCR was and is still considered the gold standard. Now, there is some limitations of doing it. It needs to be, it takes a little bit more time, approximately 4 to 6 hours, and the samples can be limited for these durations. So we're looking for some new tests that can be done from the point of view that they can give the results faster. We can reach the community. When we talk of RT-PCR, we require a specific lab, which is BSL-4. This means because of the biohazard safety, these tests can be done because of the viral getting infected and contaminated. This needs to be done in a very specified labs only. Now, with the emergence of more data, more testing modalities, we have come up with different modalities of extra tests, which are the TrueNet and CVNet. And these are cartridge-based tests, which were earlier used for other viral disease, even in tuberculosis, that was being used for these purpose. And they have been validated that they give comfortable outcome for the COVID-19 also. But again, they have limitations. They give the results within approximately around half an hour to 1 hour. But the limitation is it's a cartridge-based test, so multiple testing cannot be done at one point of time. Now, what we have come up, what the state has come up is the point of care test, and this is the need for the day, because we want to reach to the community wherein the people can be checked. There should not be an issue of the biosafety concerns for the person who are handling these samples, and that's why this point of care antigen detection and antibody detection, they are in the market now, which are being used. Now, just to emphasize, when we talk of this point of care test, they are easily doable. They does not require a very sophisticated lab or a machine, and a small kit will be helping us to confirm the test. But remember, when we use this antigen-based detection kits, we should be remembering that they have a very high specificity. This means that if you get a positive test through these, this means the patient has COVID-19. There is no confusion about it, more or less. But if patient says it's negative, it has a moderate sensitivity. So there is a possibility that those person who shows negative on point of care antigen detection test, they may be positive. So in those cases, if somebody comes out to be negative, then they needs to be confirmed if they are symptomatic. If they are symptomatic with the real-time PCR test. So this is one of the important aspects that we need to remember. Now, these are antigen-based tests, which I have just mentioned to you, and the kits are available now in the market. They are being imported. The kit is available in India. Now, coming to the antibody test. Now, these antibody tests are primarily not for the purpose of making a diagnosis. They are more for a purpose of surveillance. So when somebody shows a antibody in their samples, this means that this person has got some infection. And based on the total antibody, vis-a-vis when we talk of the IgM and IgG, based on this, we can always say that these patients are active infection or they have infection in the past and the immunity has been developed. So these are primarily used for surveillance purpose. They are not for the diagnostic purpose. They want to see that how many asymptomatic patients are emerging in the society. So all those things are being done by this antibody kits, which are available now. And again, they are showing a good amount of specificity and sensitivity. But remember, they are not for diagnostic purpose. They are primarily for the serosurveillance or the surveillance purpose. So this is what we talk about the investigative modalities for the purpose of diagnosing the case. Now, if you think of some other modalities which people are thinking of, they are not coming into the guidelines as such, but to my knowledge, people are reporting in the literature, and they say that, for example, the CT findings. Now, CT findings, they also say, sometimes I said, they do have a high specificity, but not 100%. So, but if these patients are symptomatic and they have a classical picture on imaging, specifically the CT scan, there could be a suspicion, and hence the test may be repeated for these patients, because we need to remember that there is some window period for these tests to come positive. There has to be some viral load in the samples that needs to be positive. Also, the technicalities is again an issue. If somebody has taken a sample and the sample is not appropriate, it does not contain sufficient sample, then again, because of this technical limitation, the test may show negative, but it's not exactly negative. It was the technical limitation. So having said that, based on the history, the examination findings, and based on the presentation, we should be suspicious of a person with COVID-19, one. Then, depending upon the duration of exposure and appropriate time, usually we say that these RT-PCR should be done, they are maximally positive between 5 to 7 days, because the incubation period of the COVID-19, the COVID virus, is somewhere around between 2 to 14 days. And that's why the test should be done on 5th day to have the maximum chances of picking up the true positive in these patients. So this means if the duration is not appropriate, if we go below 5 days and more than 8 days, the chances of negativity also emerges. So these are the basic issues that we talk of testing. And another the interesting phenomenon with regards to testing, I think I should also discuss here. If you think of, say, 3 or 4 months back, we were thinking of getting these tests repeated after 14 days to look for whether they have become negative or not. And that was a sign to say that the infectivity has decreased on. But then we realized that, and there's a literature or a good study from the Korean CDC, where they have seen that when the RT-PCR was positive, actually the patient was non-infected. So to understand this, when we talk of the RT-PCR, which is an antigen-based test, the virus becomes non-infective. It starts degrading inside the body, but the antigen is moving around. The antigen is can be picked up from the sampling site, and that antigen from a non-viable virus can also show positive results. And that was the reason that some of the patients were showing positive RT-PCR even at 2 weeks and 3 weeks. And that's the reason they have stopped doing it. And that's a major policy change which has happened at the time of discharge. We remember in the beginning, somewhere in the March, we used to have 2 negative samples sent at 13th or 14th day before the patients were being discharged. But now we are discharging the patients on a 10th day, and it has been found that the majority of patients become non-infective at the 9th day. And that's why the discharge policy has been changed now, discharge at 10th day, and they can have a quarantine at home for another 1 week. So this is the diagnostic modality and looking for the negativity. But remember, when we talk of the immunocompromised patients or patients with cancer or patients who are like, say, renal failure, the infectivity may exist for a little longer duration, and that needs to be considered when we are managing these patients. Back to you,
Dr.
sir.
Rakesh, Dr. Rakesh, if you could tell us about the point of care antigen testing. See, once it starts spreading to a large number, probably this is the big ticket item, and this will make a diagnosis sooner and, more importantly, reduce the spread. So what is the new point of care antigen testing, and what is ICMR and AIMS advising?
So this point of antigen detection test has been developed in which we do not require a sophisticated lab. It can be done in even small primary healthcare centers, and that is the beauty of this test. So what is recommended is that now these tests are being done at various places, especially like if, say, we have identified certain containment zones, and we're going to look for that in containment zones, how many are positive, and also people who are working in the healthcare worker, like the police personnel, the nursing staff personnel, the doctors who are working there. So these group of people needs to be identified to look for whether they require testing or not. And these are the group of people where these tests can be done in the periphery, and we can identify from those high risk population. And that's why the ICMR has recommended that they may be done by different people at various places, so that even those group of patients can be picked up even if they are asymptomatic, especially from a hot zone, especially from a containment zone which are being maintained by state and central governments. So that is how the point of care antigen detection test, which is coming in the form of a standard Q COVID-19 AG kit available, and that is quite having a high specificity, and that needs to be done in the periphery rather than requiring a sophisticated lab for the same. Over to you, sir.
Yeah. Thank you, sir. And these are questions which have always troubled us. And I want you to tell us, right from CBP, let's say tomorrow we start seeing cases of just fever, nothing else. Will CBP be able to give us any clue? CBP, CRP, simple things that we can do on OP basis. And let me extend the question. Now that this is inconclusive for whatever reasons, can simple tests which we can do at an outpatient clinic level, like ferritin, procalcitonin, can they help? And your final word on both X-ray and CT, is it screening Is it diagnostic or is it in a selective situation?
I think this is an excellent question because we are struggling with which investigations to be done and which needs to be available. And there is a whole array of various the clinical chemistry, the hematological, the coagulation profile, the imaging studies. They have all come into various studies and they have all been used. Let me come one by one. One thing I need to specify from the beginning that these are not the diagnostic tests to diagnose the COVID-19. So this needs to be made clear. The suspicion may be raised based on these changes, these parameters, especially like the blood counts, the serum ferritin levels, or the D-dimer levels, or CT scan finding. They can give a high index of suspicion that these patients would have. But the diagnostic confirmation would be based on the RT-PCR, or now we can say TrueNet and CBNet, or an antigen-based test. That needs to be done to confirm the diagnosis. These modalities, which you just mentioned, they are more of differentiating between the severity of the disease. So when we say mild to moderate and moderate to severe, and I think in subsequent sections, you'll be discussing about the various therapies. Probably most of them are experimental, but to include those therapies, these test modalities are important to take a decision that when to add and which modalities. Coming to the complete blood counts, it has been seen that there is some amount of lymphopenia and leukocytosis along with neutrophilia. People have identified the NLR ratios which are changed in COVID patients, and they have been seen that the neutrophilia happens with the leukocytosis, and that's why the NLR ratio changed, and hence they are indicator of the severity of the disease as well. Coming to the serum ferritin levels, as I said, as you already mentioned in the initial sections, that the COVID-19 is a inflammatory state, and when we talk of shifting from mild condition to moderate and severe, this inflammatory cascade that happens in the body, which is usually multi-systematic, is happening. And this inflammatory cascade leads to a lot of release of various cytokines in the body, and that leads to production of some of the other products. And that leads to the, say, increase in the serum ferritin levels that has been seen. Because of the coagulation profile changes, the D-dimer levels are also increased. So these modalities, the procal, the serum ferritin, and D-dimer levels are the indicator of the inflammatory signs. With regards to the procalcitonin, there are a couple of studies, though there are some conflicting outcomes from these studies. Procal is primarily an marker of these septic focus inside the body, and it is usually seen with the bacterial infections, not found to be much related with the COVID-19 as such. They have been seen that the initial studies procal level may be lower, but in addition to it, the secondary infection rates are also seen in this group of patients, and subsequently procal level may is high. Serum ferritin and D-dimer levels are rising. As the severity increases, these levels increases, and the patient comes from mild to moderate and moderate to severe. Now, coming to the X-ray and CT, these are the imaging modalities, and maybe some sort of ultrasound, which has also come into play. I'll add to it. These are more of an, you can say, actually not screening for the disease, but screening for the severity of the disease actually. So if you have some infiltrates on the CT scan or the X-ray findings, this means the patient requires some monitoring. He's not simply a mild cases. He requires probably a more amount of intensive monitoring and treatment. And as those opacities increases, sometimes on the bilateral lungs, then that severity increases further. So this will help us to triage these patients to the severity category and this management. So since the government and the various state governments are talking of the COVID care centers, the hospital-based centers, and the ICU setup. So these modalities probably will help us to look for that what type of severity these patients have and how they can be taken further on. Not only these markers, but there have been certain changes in the other levels also, like the increase in the ALT, AST, the increase in the LDH level, because the multifunction disorders happen, so the LFTs and KFTs also may get deranged. The thrombotic phenomena happens, so cardiac, the troponin levels may be a little higher. So what I say to, in a nutshell, when we talk of these investigational tools, including imaging, they probably give us an idea that patient has a disease and the severity based on their serial monitoring, whether their patient are deteriorating or they are responding to the supportive care we are providing. So these markers all will be included into that group. So to summarize, when we say regarding the testing and including the various biochemical parameters, the RT-PCR still remains one of the gold standard modality of confirming the COVID-19 patients. With the availability of newer tools, which are point of care tools, can be done in periphery, does not require a big sophisticated lab. These kits, which are antigen based, can also be used for diagnostic modalities in the field. If somebody comes to be positive on those kit based tests because they have a high specificity, they are confirmed COVID-19. But in case if the antigen based kit test comes out to be negative, but the suspicion based on the symptomatology is high, these patients must be repeated with RT-PCR to confirm that they are really negative. Coming to the antibody-based kits, these are primarily for the surveillance purpose, the epidemiological surveillance purpose in various areas. They are not for the diagnostic modalities as such, but they will be helping us to see that how much in the community the infection is spreading, how much is the population which has mounted antibodies, and that will be the percentage of looking for the asymptomatic patients in the community which probably has got infected, and they are mounting the immunity by showing the positive antibody. Probably the looking for IgM and IgG will help us to differentiate between an active infection and infection in the past. That needs to be done. But some of these antibodies are giving us total antibody rather than differentiating between the two.
Thank you so much, Dr. Rakesh. A few questions, and I request all the attendees to please type in your queries and comments as you see the slides, because we'll try to do it at the section itself. Quick answers, Dr. Garg. Yeah. What about the role of LDH? Is it specific, sensitive, just another investigation that turns positive? I think
if we see a couple of studies which have been published from Wuhan and America, the LDH levels have been found to increase to a tune of somewhere around, say, 30–40%. Up to the 80%. So probably in a nutshell, we can say the LDH levels are increased because of the inflammatory state of the patient. But we cannot say that these are the diagnostic marker of COVID-19. But yes, because of the systemic inflammation, LDH are increased in COVID-19 patients, and that indicates even, in fact, the severity of the disease involving the multi-organs.
Thank you, sir. IL-6 levels?
IL-6 have come to a very important mark, because IL-6, and when we talk about the drugs also, the cytokines, especially the IL-1 and IL-6 were considered, but IL-6 has definitely been found to have a more role in the respiratory issues. And the increasing trend of IL-6 over 24 hours is a very good indicator of the increased morbidity with regards to respiratory parameters, and then people are thinking of starting them on IL-6 inhibitors. So IL-6 markers are also one of the modalities that needs to be looked for in patients with COVID-19 for severity. Prognostic, and probably the use of the experimental drugs like tocilizumab when somebody wants to use it. So they will have to have IL-6 levels and look for how far they are rising. So by using those experimental drugs, probably you need a level of IL-6 before you start them on IL-6 inhibitors.
Thank you, sir. We'll proceed with the next section. We'll please continue to type in your queries related to testing, and we'll definitely revisit them and discuss them with all the panelists as well. Now I welcome Dr. Srirang Apkari, our own IMA Hyderabad City man, to tell us more about mild cases. Dr. Srirang, these are the current protocols released last week from AIMS, which are guidelines for management of various types of COVIDs. Can you please take us through the management of mild cases? This happens to be the majority of the COVID positives that we are all seeing. So if we can actually get this right, we'll be able to handle this pandemic effectively. Over to you, Dr. Srirang.
Yeah, thank you. Am I audible?
Yes, sir. Go ahead.
As you rightly said, about 80–85% of patients will be having a mild disease, and the mild disease has been categorized as stage 1, and it has again been subdivided into A, B, and C groups. So in the mild disease, the A group is asymptomatic but positive for COVID-19. The B group is symptomatic URTI without any comorbidities. That is, you have fever, dry cough, some feeling of breathlessness, myalgia, but without comorbidities. And the group C is the symptomatic or URTI with comorbidities like obesity, age greater than 60 years, other diseases like diabetes, hypertension, COPD, immunocompromised states, chronic kidney disease, etc. So when we divide the mild disease, which forms the predominant into these three categories, then we get a sense of idea what is happening. Now the very mild, that is the asymptomatic or the pre-symptomatic cases, what has been advised is you can also be managed at home because we are finding it extremely difficult to find beds for these patients. Now when we manage these patients at home or a COVID care center, they need to be very carefully monitored because as all of us know that it is a continuum or a spectrum, so that somebody can transition from mild to moderate, moderate to severe very rapidly if we are not watchful. And every stage of the mild disease, be it A, B, and C, we need to watch out for some red flag signs. As already discussed by the previous panelist, the neutrophil lymphocyte ratio is an important red flag sign. That ratio being more than 3.5 should raise concern that there is going to be some problem. Similarly, somebody having a resting tachycardia, which is easily clinically monitored sign, we can know that there's going to be some problem. We need to very carefully look, are we missing anything in addition to the symptomatic presentation? Similarly, in the group C, where we have the red flag signs include a high NLR ratio, the PF ratio less than 300, or desaturation on 3 to 4 minute walk, which can easily be done. Ask the patient to just walk around and check the oxygen levels with pulse oximeter. If they are falling to below 94 or 95%, then you know there's going to be a problem. Or other inflammatory markers like raised CRP, ferritin, D-dimer, LDH we just discussed. These are the red flag signs for the group C. So all patients with mild disease, first of all, need to get some baseline investigations done, which have been already discussed. ECG is important because of two things. While one is we are using azithromycin, but the latest update says that azithromycin again is not to be used, and we are also using hydroxychloroquine. And suppose we are going to manage somebody at home without a ECG and giving hydroxychloroquine, that may be a very dangerous thing. Although we have a great deal of experience of using hydroxychloroquine in connective tissue disorders, because this is an inflammatory state with so many other things and ongoing medications, including antibiotics like macrolides, we need to be doubly sure about the ECG. So for all mild patients at a baseline, please get a complete blood picture, a renal function test, random sugar, liver enzymes, and an ECG along with a chest radiograph. As rightly said, the role of CT scan will come later. Very early CT may give sometimes a negative result and sometimes a seemingly false assurance that everything is well. But CT generally about 4th, 5th day we have seen in clinical practice those typical subpleural, lower lobe predominant, bilateral, fluffy or ground glass opacities which are seen suggesting patchy pneumonitis of a viral pneumonia. As far as the treatment of mild disease is concerned, there has been few controversies regarding that as to what to be given. Some suggest asymptomatic people without any comorbidity just watch. Others have even recommended hydroxychloroquine for them. Now the ICMR advises hydroxychloroquine predominantly for healthcare workers as a prophylactic dose, which is 400 milligram twice daily on day 1, followed by 400 milligram weekly for 7 weeks. But when it comes to treatment of mild cases, the dose of hydroxychloroquine is 400 milligram twice on day 1, followed by 400 milligram divided in 2 doses for the next 4 days, total of 5 days. So whenever hydroxychloroquine is being used, QTC monitoring should be done very carefully, and it is not to be combined along with azithromycin because the danger of QTC prolongation with these two drugs becomes much higher when either used alone. Other way around, other antibiotics according to the local antibiotic policy also can be used, which may vary from institution to institution. Now, what has changed in the mild disease is that since there has been a lot of trials for and against using hydroxychloroquine, the hydroxychloroquine, as we all know, the mechanism of action of this drug primarily relates to its in vitro activity where the acidity of the endosomes is altered and therefore the viral entry and all is difficult. So there is now the newer drug which has also been recommended early on with high viral loads for mild disease, and that is favipiravir. Now favipiravir has been very recently launched It is been approved by the Drug Control Authority, basically on a EUA approval, so that the use in this can be known. Now, favipiravir is a drug which was originally used in Japan, especially for influenza viruses. Now, this drug was tried in many trials, and a lot of studies on favipiravir are actually going on. So it was quite surprising that it has been recommended by the drug authorities for emergency use in such a condition, but all these data is to be reported to them so that they can take a further action on that. Favipiravir, as we know, is a RNA polymerase inhibitor. It basically gets activated to an active form, which is phosphoribosylated favipiravir, and then that acts as a substrate, and the RNA polymerase activity comes to a halt, and viral replication actually comes down. The problem with favipiravir is it was developed for influenza, especially resistant influenza viruses, which are resistant to your regular oseltamivir. So this drug is to be used in the early course of disease, and it is as an alternative to hydroxychloroquine. So favipiravir, the dosage is quite high. It is about 1800 milligram twice daily. The tablet comes in 200 milligram tablet. So you'll have huge pill burden. 1800 milligram twice daily on day 1, followed by 800 milligram. Some have recommended for about 7, some others have recommended for about 14 days. What they found in the limited studies, especially done in Shenzhen in China, is that the recovery is much faster when they have compared to a combination of lopinavir ritonavir. So favipiravir in some small studies is there, properly designed randomized trial. The reports of favipiravir are still awaited.
Thank you, sir. Could you tell us about home isolation, because this is going to be the main modality of treatment for majority of the COVID positives. So just in a nutshell, the key aspects of home isolation for COVID positive patients.
Yeah, as I said, it is the asymptomatic or a very mild symptomatic disease can be home isolated, but they should be under, again, follow-up with a regular physician who can monitor for red flag signs, and the transition to a moderate or a severe state is not missed. So whenever there is home isolation, certain criteria have to be fulfilled. They do not generally, if they are having a lot of comorbidities, they are on multiple medications, then that becomes a bit risky, especially giving drugs like hydroxychloroquine. So when we have a home isolation for a patient who has a very mild disease, what is prerequisite is that there should be a 24/7 caretaker who can take care of the patient. Other things which are helpful in a home isolation is that you have a thermometer, you have a pulse oximeter with you. If you can monitor your blood pressure, that will be even great. And the baseline tests have to be done initially. The caretaker, when he enters the room of the patient for other caregiving, etc., should be wearing a mask, and hand washing as per the protocol should be regularly done. What is recommended is that food and other eatables should be given in disposable containers so they can be discarded. Minimum contact with the patient is to be maintained, and at all times the caregiver can be at a quite distance from the patient. Patient also should be wearing a mask and also should report any warning signs such as giddiness, chest tightness, feeling or shortness of breath, unable to breathe properly, and in sometimes children, bluish discoloration, if it is there, these are warning signs and they need to be reported very rapidly.
Thank you, sir. So that's about home isolation, and majority of them will be able to handle this. Now, few questions, and this is what we have been seeing in the last few days, especially. What is the role of pulse oximeter, Ayurvedic drugs? This is in specific to these mild cases which you're talking about.
Pulse oximetry is a good modality by which you can monitor the safety of a patient. Anybody which is having a saturation about more than 95, significant hypoxia and lung involvement can be ruled out to a certain extent. There's also something called as the happy hypoxia syndrome. Normally in other conditions, what we would find is that somebody who's desaturating would appear quite distressed, having respiratory and accessory muscles being acting, and he's not comfortable. But I have personally seen a lot of patients with this COVID where they're comfortably talking, no problem, saturation is as low as 82. So pulse oximeter gives you a correct idea that whether the person is transitioning at home isolation or mild disease is progressing to moderate to severe disease. Pulse oximeter is easily available, and we need to monitor the saturation. Other important thing is even a baseline saturation, if it is normal, just the patient walks in his room for about 3 to 4 minutes and there is significant desaturation falling below 94, then it indicates that there is significant lung involvement, the ventilation perfusion is not happening properly, and therefore you can step up to a moderate level care. As regards to Ayurvedic medications, now there are Ayush Ministry which is encouraged a lot of indigenous medications first as immunity boosters. We all know immunity plays an important role, and a lot of home remedies have been used. So these include your regular gadas, turmerics, and all kinds of stuff. So what is also coming is the Ayurvedic drugs, the latest being the Coronil, which has been announced by Baba Ramdev. Now this again contains certain mixtures of ashwagandha and other ingredients supposedly studied under a trial, but the license for which it was applied did not mention anything about corona. So unless it is validated by the Ayush Ministry, I don't think that can be recommended. Clearly, they have stated that this is not only an immuno booster, but it is to be used as a treatment with success, except for life-threatening events. But I think we should let the Ayush Ministry first verify the claims, see the studies, and only then probably have some usage of that in clinical practice.
Thank you, Dr. Sriram. That's exhaustive information, and I'm sure these points are of much relevance in the current scenario that we are all on. Thank you so much, and we'll take up questions which are related to mild cases as soon as we finish. We now move to the second category of moderate cases, and I request Dr. Vinay Shekhar, the professor and head of the department General Medicine at Gandhi Hospital, to please tell us about the current management protocol for moderate cases of COVID positive, and please tell us what is the role of these investigational therapies. I have shown a slide where government of US has a certain protocol and they've said nothing is FDA approved, all of them have no role. What is it that government of India, especially in the AIMS guideline manual, and also what has been your experience at Gandhi? We would love to hear from you what has been your experience in using any of these drugs apart from management of the cases at Gandhi. Dr. Vinay, over to you. Dr. Vinay has just left the panelist group. I'm just adding him back and then he should be able to respond. Dr. Vinay, you're back here in the room, in the panel room. You may please unmute and go ahead, sir.
Can everybody hear me?
Yes, sir. Please go ahead.
Yeah. So thank you, Sri Krishna, for giving this opportunity, and also I'd like to thank one and all who are on this webinar. So basically speaking, most of the things have been covered in the last 2-3 sessions. But the only thing what I'm going to discuss really important about these investigational therapies. First of all, what is a moderate case? A moderate case is a pneumonia with no signs of severe disease. That's wherein we see a respiratory rate more than 24 per minute with SpO2 less than 94 on a room air. So what are these cases we are going to deal with? So we need to admit such patients into a dedicated COVID health center. So wherein followed by an oxygen support. So most of these patients where we are seeing, we are admitting a lot of cases in our hospital, wherein we have kept it intermittent. I mean, there's an oxygen support area wherein they have been given oxygen support, which is a most important component of the treatment and management of this COVID patients. So the main target to get is to get a target of SpO2 between 92 to 96%. Maybe in a COPD cases, we may get target little less, 2 to 4%. And a preferred device for the oxygenation is rebreathing face mask is the ideal one. Or when you are using a nasal cannula, we can put a N95 mask over it. Okay, and what I advise is awake proning may be used as a rescue therapy. So the awake proning would be a better option. And all patients who are getting oxygen, they need to get a ECG, a 12-lead ECG every day. That's what, and follow up with most of the investigation which was discussed earlier. We need to do C-reactive protein, D-dimer, and ferritin, which are the inflammatory markers. which should be done at least repeated every 2 to 3 days. And apart from these special investigation, we need to do CBP with a special emphasis on discover the differential count and absolute lymphocyte count. And also there, we need to do a baseline liver function test and also renal function daily. Okay, and what is the treatment? What we giving for these patients is hydroxychloroquine. We're advising 400 mg BD for first day, preferably after food, followed by 400 milligrams once a day for 4 days. So generally, need to be careful whenever we're giving, as discussed, it is actually whenever we're giving hydroxychloroquine, we need to have a baseline ECG assessment. And for these, apart from the hydroxychloroquine, we are giving, we need to give methylprednisolone 1 milligram per kg body weight 3 days, preferably within the earlier the better, maybe at least within the 48 hours of admission, or we need to add this steroid whenever the patient needs increasing demand for the oxygen. And as far as the anticoagulation is concerned, a prophylactic dose of low molecular weight heparin or unfractionated heparin is also recommended. For example, enoxaparin 40 milligram daily subcutaneous can be given. And all these patients need to be monitored you have to monitor, and if need to be shifted to the dedicated COVID hospital if any of the following things occur. Increasing work of breathing, if as suggested by the great activity of the axillary respiratory muscles, and hemodynamic instability, and increase in the oxygen requirement. That's what is all the three are the parameters which you have to monitor and shift according to the based upon that. And as I told earlier, there are so many investigational therapy. At present, the use of these therapies based on the limited evidence that is available. So as far as the situation arises, more and more data would be available, and it can be all these data can be incorporated and recommended and upgraded. Further use of these drugs is subjective, because the most important constraint is availability of these investigational drugs. We don't see probably in India, a country like India, where the availability may be a one issue. So currently these drugs should only be used in the defined subgroup of patients. So as far as the investigational therapies are concerned, the one what the antiviral drug, that is remdesivir, which is maybe considered in patient with
Hello. No audio, please.
Yes, sir. I think sir would have got logged off. He said the internet at his place is a little flaky. Let me just check if I can find him. Yeah, I can find him out. Yeah. Okay, we'll wait for Dr. Vinay Shekhar to come back and then resume on this. But let us quickly go next to the severe cases. Dr. Srinivas, if you can start with these drugs and then take us through when the moderate case becomes severe. And I have one personal question which I have not I've not found any data on it. What is it that actually tips these moderate cases to become severe? It is not that all of them are only the immunocompromised, or the elderlies and those who are having comorbidities. We are seeing people without comorbidities also becoming severe. So is there a prognostic indicator that can tell you which case becomes severe? And then what is the role of these three investigational therapies? Over to you, Dr. Srinivas.
Yeah. Good afternoon, sir, and good afternoon to all the senior members of the IMA, and thank you all for giving me this opportunity. Now, what changes a moderate or mild case to a severe case is something which is very important to know, because that's when we need to intervene when the moderate case shows some signs of impending severity. Now, if you start from the basic presentations, a persistent fever that's more than 102 or 101 beyond the 5th or 6th day of the illness, despite appropriate therapy with hydroxychloroquine, azithromycin, and probably favipiravir or one of the lesser antivirals, is definitely an indication that something more advanced is going to happen. Most importantly, if the neutrophil to lymphocyte ratio doesn't get better, or the D dimer which was elevated doesn't get better or starts elevating despite your appropriate therapy, or your ferritin starts rising after an initial fall, these are all patients on day 5 or day 6. If these trends are seen on your charts, you are looking for trouble. Your patient is going to go to trouble. The interleukin 6 levels is one aspect of the story, because some of these patients who deteriorate do show the classical features of a cytokine storm, and they have a several fold elevation of the interleukin 6 levels. But there are also certain subgroup of patients who seem to be getting better in the first 4 or 5 days, and then that gives you a sense of confidence or a complacence probably, and then 6th or 7th day they deteriorate, and these patients end up having right ventricular dysfunction and have hemodynamic instability. This probably is the microvascular thrombotic manifestation of the COVID infection. Some of them have had well demonstrated pulmonary emboli, but most of them behave like a a submassive pulmonary embolism. So cytokine storm is one thing that tips them over, and a microvascular thrombosis is something that is tipping some of them over. So when you find these patients tipping over into this kind of a scenario, you need to do the basics first. So what is a severe disease? Somebody whose respiratory rate is more than a 30 per minute, and somebody who's saturating less than 90% on air, or struggling to maintain above 90 with face mask, or with a high flow, is somebody who's probably having a severe disease, and he should be in a dedicated COVID hospital, which is capable and ready to manage these patients. Although initial stages when the disease started out in Wuhan, we thought that non-invasive ventilation may be dangerous because of the exposure to aerosols. But if done carefully with proper personal protection equipment, and if you have the facility in negative pressure rooms, NIV is a good alternative to invasive ventilation, because invasive ventilation results are not as good in COVID ARDS as they were in other types of ARDS, including the H1N1 ARDS. So a cautious trial of CPAP preferably with a helmet interface, or you could also try a high frequency, high flow nasal cannula, which generates some degree of PEEP while giving you a control over the FiO2 is probably important. What is more important in these patients with severe disease is the hemodynamic status. And these patients, because of their mouth breathing and the work of breathing, tend to become dehydrated very soon. So the better you address their volume status, the more aggressively you maintain euvolemia, the better your chances of not tipping this patient into hemodynamic failure. At the same time, avoiding positive fluid balance is also an important step which we should be looking at while managing these patients with severe severe COVID respiratory involvement. Steroids have been used ever since the disease started. Initially, it started with methylprednisolone, which still continues to be the mainstay of treatment. After the recent trial of dexamethasone, there is some tendency to shift to dexamethasone, but we need to remember that dexamethasone has got some interactions with remdesivir, and it's also got some dosage effects on chloroquine, hydroxychloroquine as well. So if your patient is already on hydroxychloroquine or remdesivir or both, and those are the life-saving drugs, you may have to go with methylprednisolone rather than dexamethasone. But if non-invasive ventilation and steroids don't help the patient's work of breathing to come down, we have no choice but to intubate these patients. And once the patient gets intubated, we know that this is COVID. We know this is COVID ARDS, but we should never forget the basics of intensive care. We should never forget the basic principles of ventilating an ARDS. Yes, there are people who, there is two types of ARDS, the one with normal compliance and the one with bad compliance. What we are talking about is the lung with bad compliance, where you go with a low tidal volume conventional ARDS-NET strategy of 4 to 8 mils per kilogram of ideal body weight. If the patient has shock, then you know your markers of shock, get your lactates, target them, try to bring them down as you do for a septic patient. And if you are using one of the immunomodulatory drugs like tocilizumab, please use appropriate antibiotics. Do not overdo antimicrobial therapy, use your local antibiogram and give the appropriate antibiotics therapy. And because we are ventilating a stiff lung, use appropriate sedation, and if necessary, in the first 48 hours, we go with neuromuscular blockade as well. One of the important determinants of good recovery in patients with ARDS is nutrition. So the earlier you start attending to the nutritional requirements and the stress factor of nutrition, the better you will do. So early enteral nutrition is probably the best way of taking care of these patients. So while you ventilate these patients, as you do with other ARDS patients, once you intubate this patient, you should be ready with a plan on how I'm going to wean this patient off. So the moment the oxygenation, the work of breathing, the lung compliance permits you, we should be able to wean off the sedation and assess the patient's readiness for weaning. So lightening the sedation should be part of your protocol, despite the fact that we are dealing with COVID. And because we are using immunosuppressive drugs like tocilizumab and maybe steroids, your attention to infection control should be 200% more than what you would be doing when you're doing your other patients. So reduce the incidence of VAP, use a continuous closed suction system, keep the head end up, do not use nasotracheal tubes. Even the feeding tube should be through the oral cavity, right? Do not change circuits ad lib, and change the circuits only when they are soiled, and change the heat and moisture exchangers if it malfunctions, or every 4 to 5 days. And as we spoke in the discussion on mild and moderate cases, DVT prophylaxis and therapeutic heparinization are mainstays for the treatment of severe COVID infection. So if your D-dimers are more than 1,000, then probably you should go with a higher dose of enoxaparin, maybe 60 milligrams, 1 milligram per kilogram body weight twice a day. You may also target with unfractionated heparin, but our own experience has been patients with the internationally accepted nomograms tend to bleed. They're bleeding badly from vascular access. They're bleeding badly into their lungs as well. So we probably are better off by using the therapeutic enoxaparin rather than go with heparin. However, single mode prophylaxis may seem to be inferior. So we should go with something like a sequential compression device plus a pharmacoprophylaxis for better DVT prophylaxis in these patients. And of course, just like we have attempted to decrease the incidence of ventilator-associated events and incidents, we should also look at reducing the number of bloodstream infections, because these lines are going to be handled too often. You're going to give them steroid, you're going to give them other drugs. So the attention to the lines and the care of the line should be supreme. And of course, we should be we should be able to prevent pressure sores in these patients. They're all paralyzed. They will be very heavy. The housekeeping staff and the nursing staff are under strain, but you should not forget that turning position is probably very important for these patients. So, and because these patients are on steroids, they are hypoxemic, they are on mechanical ventilation, and they are getting the therapeutic heparin. So they are prone to bleed from the gastrointestinal tract as well. So they are high risk candidates for stress ulcer bleed. So a proper stress ulcer prophylaxis with either a proton pump inhibitor of your choice or a H2 receptor antagonist should be part of your treatment algorithm. And once your patient actually starts getting better, and when you put them on support mode of ventilation, when they're off sedation, they're awake, following commands, able to cough, we should try to mobilize them and start exercising them so that you avoid critical illness, polyneuropathy, and ICU-related weakness.
Thank you, Dr. Srinivas. Can you please tell us about these three investigational therapies?
Yeah, so one of the important drugs which is currently making a lot of rounds and buzz around the country is remdesivir. Now, this drug is currently being licensed for use under emergency authorization. Those are patients who, this is for patients who have already crossed the mild stage and are in the moderate stage of disease, requiring oxygen, requirements are increasing. This is a drug you should consider. But before you do that, certain caveats are necessary. You need to look at certain caveats. It's not for the pregnant lactating lady. It's not for pediatric COVID. It's not for those who have an AKI requiring hemodialysis, whose GFR is less than 30 mL per minute. And of course, those who have ongoing liver dysfunction. So these things have to be ticked in the checklist before you prescribe remdesivir. So that's the yeah. So convalescent plasma is an interesting concept. Convalescent plasma may be considered for those patients, again, those who have moderate disease and whose oxygen requirements are increasing, but there are certain caveats. Not every convalescent patient is eligible to donate plasma. We need to know whether he is negative by 2 consecutive swabs. And then you need to know what his titers are. A neutralizing titer of 1 in 1, about 1 in 640 is what is recommended. And ABO compatibility and the donor plasma cross matching is essential. And we don't know who comes to you with an IgA deficiency. It's very, very difficult to get that history when you're treating a COVID patient, but that's one of the reasons. So this is again something that uses the antibodies generated by somebody who successfully overcome the infection and is trying to help somebody else. The other one is tocilizumab. Tocilizumab is a immunomodulator drug which has been available in the market for different diseases, but now its role has come as an interleukin modulator, especially for those who show evidence of cytokine storm. So for this, you need to measure the interleukin level. So suppose your upper limit of normal for interleukin is only 15 and the lab value is 30 or 40, patient doesn't qualify for tocilizumab. So you need to know whether the interleukin-6 are more than 3 times or 4 times the upper limit of normal. And the patient should be, as I said, monitored for secondary infections. You have to look at the ferritin. We also look at the CRP. And did this patient have tuberculosis in the past? It's something we need to be asking before you put this drug on to the patient. And the dose is, you give it 800 milligrams at one time over slow infusion over an hour, and then you check the response, you check the interleukin-6 levels, you check the ferritin, and then you give 2 doses. Not more than 2 doses are recommended with tocilizumab. They're all having mixed results, but there are always subsets of patients who respond to it, and there will always be subsets of patients who do not respond to this.
Thank you, sir. So that finishes the 3 segments. What we'll do now is take up every question that has been put up. We deliberately try to keep it very minimal and give only the recommendation. We'll start with Dr. Rakesh. If you're around, if you could see some of the questions which have come related to testing, and if you would like to go first and answer them. Request Dr. Srirang and Dr. Srinivas to look at the mild and Dr. Srinivas to respond to both the moderate and the severe cases. If Dr. Rakesh, please go ahead.
Just hold on, let me. Somebody asked how much these IgM and IgG are protective. I think though this is related to the prognostication, the IgM and IgG obviously are the protective antibodies. There are some issues that when we were looking for the donors among the group of patients who can give for convalescent plasma, the antibodies were not to the same level, and almost 1/3 of these patients probably were not suitable for giving the plasma because their titers were not appropriate. But yes, these antibodies are protective in fact, and once they start developing, obviously they will be helpful. Now with regards to the IgM and IgG, we should be careful that IgG is the antibody which develops a little later and gives you a protection for a longer duration. For how long, we do not know. We do not have a data as of now. But yes, we need to look for IgM. Probably the infective phase and where the patient needs to be isolated as such. Should each and every negative antigen test be subjected to RT-PCR? Yes. As of now, because those are the point of care tests, I said they have a high specificity. This means that if they come out to be positive, then the patient will be positive. They will not be giving a false positive test as such. But they have a moderate sensitivity. So they will not be ruling out a positive patient who are showing negative on these tests. That's why if a patient is symptomatic, comes out on a point of care antigen test has to be negative, and the patient is symptomatic with high index of suspicion, these needs to be mounted for RT-PCR. And as per ICMR guidelines also, they need to be referred to some center. That's why the places where this the point of care antigen test is being done, are supposed to refer these patients to the centers or the labs or the hospitals where the RT-PCR can be done about these patients. Do the specific IgG neutralize the viral load? I'm not very sure if any specific IgG is being measured by some test or not. I think this is not very clear. But yes, the neutralizing antibody is what is required for the convalescent plasma therapies, and that needs to be looked for. As some of the places this is available, and they are looking for this neutralizing antibody before the plasma is collected from these patients. The finding on the HRCT chest in the COVID, this is an interesting question. And I think there was a couple of good papers where they found that how the opacities will come up. The initial stages will be a lot of opacities. They can be into the one lobe, but they can be in the both lobes as well, which can increase to downwards opacities, which is something like an ARDS feature on both the lungs, and that needs to be looked for on the imaging section for these patients. Even some cases wherein the opacities have been seen in the mediastinum with pneumomediastinum, those are also happening in these group of patients in some, and that needs to be looked for. The radiological findings positively with RT-PCR negative cases. Now with this imaging section, the radiologists are able to pick up those patients who have a high index of suspicion. And we need to remember that we are not redoing the radiology here. We need to have a balanced approach between the two based on the clinical symptomatology and based on the findings on the CT scan. We can make a combined decision that the patient is highly suspicious of COVID, and then we can look for testing using RT-PCR and so on and so forth. CRP D-dimer arrays patients also raised. I said D-dimer is raised in this group of patients because of the coagulopathy that happens because of the inflammatory cascade leading to thrombosis in the small capillaries in various systems, and that's why the D-dimer starts rising in these patients, and that needs to be looked for. Now, C-reactive protein is an indirect response by the liver from the inflammatory markers, especially the interleukins, interleukin 1 and especially the interleukin 6. So when
Yes, go ahead, Dr. Rakesh.
Right. Okay. And when you talk of how much these IgM and IgG are protective, I think, okay, I've come back to the same question. I think they are protective.
Yes, sir. I'll just summarize the questions now for a quick answer. Troponin INT, are they increased any value of decisions?
Yeah, they are specifically prognostic markers because it has been seen because of those thrombosis and other phenomena. There are some increase in the levels of troponin I also, and that should be looked as the overall clinical progression of the disease in the patient, and that's why there will be a prognostic marker. Though probably the change in therapy, I think our previous speaker has very nicely mentioned the use of the low molecular weight heparin in these patients, so that these thrombotic phenomena not need to measure coronary phenomena, but yes, they are the indicative markers.
Thank you, sir. I request Dr. Srirang to please come online. A couple of questions, Dr. Srirang, I'll put them across to you. The first one, can we classify patients without testing? Is there a way in which clinically we can triage them?
Yeah, most of the classification parameters are basically clinical itself. So when we said about mild disease, it is early disease without any breathlessness, and pulse oximeter, the simple measure you can let you know whether hypoxia is there or not. Moderate disease, when you talk moderate and severe, again clinically you can make out to a certain extent, but when you are trying to see moderate disease, chest imaging becomes very important. Other parameters, inflammatory markers, etc., probably help us differentiate between moderate and severe disease. But simple things which help you to clinically classify is only upper respiratory tract infection, no breathing difficulty, no red flag signs like your chest tightness, giddiness, and no desaturation on walking. These will help you classify the disease.
Right, sir. Next question, what are the chances of reinfection and the duration of immunity? And this is a question we've been hearing since the starting. Does a person who had it once, will he have it again?
This actually began when there are new positive cases emerging in South Korea when they controlled very well and then they thought they were second wave. But most of these cases, as was told by the previous panelists from the AIMS, they were dead viral particles which were actually getting defected, and reinfection cases as such have not been reported. So generally immunity tends to last long. There's a recent article which says that the IgE antibody was detected as long as about 2 to 3 months. But absence of antibody, does it indicate susceptibility to infection? We are not sure yet. It is very early days. I also had one more question regarding nutritional supplements. They have been recommended at all stages of the disease, and these include zinc, vitamin C, vitamin D, and they are helpful in probably recovery. There's no trial as such, but they have been recommended. You generally tend to add these in prescription of patients at all stages of disease.
Right, sir. Let me put up this question to you as well, Dr. Srirang. Role of ivermectin, doxycycline.
Yeah, no, doxycycline, as we know, has some immunomodulatory properties. Ivermectin, 12 milligram per day dose for about 3 days has again been used. There's no recommendation, but people have found where HCQS was not being able to use, they've used ivermectin, have favorable results. So the ivermectin and doxycycline per se can be used both as an antibiotic as well as immunomodulatory agent, and especially when you use doxycycline, the risk of prolonging QTC when you use azithromycin and HCQS together is not there.
Role of zinc and vitamin C. Is it more to improve the immunity, or do they actually reduce the viral load or prevent any complication?
I don't think they would have too much effect on both the complications as well as the reduction viral load. Vitamin C has also been tried earlier in ARDS due to different etiologies with some varying benefit. So I think that probably would be more of to do with immunity.
Right, sir. And the last question to you, I'll ask this to the other panelists also. How are you managing your team? Because the question here was, how do we plan quarantine for the healthcare workers? We often see nowadays many of the doctors, nurses, paramedics getting positive. We know our healthcare staff are limited. They just suddenly can't, no, you can buy ventilators also, but you can't just buy and create healthcare staff. On top of it, you are getting people who are getting COVID positive and they are out of bounds for work. How are you managing this? And is there a plan B also for us in the month of July?
No, I think the ideal way is to have somebody on and off for particular shifts. They are on during a week and then off during that, but that depends on what kind of people you have at the baseline. As you rightly said, if somebody gets affected, your whole program may get derailed, and therefore you need to have a backup. Everybody should be following that protocol very stringently. Basically, the personal protection equipment, hand washing should be stringent. So that way we can, to a certain extent, control that. And in a COVID unit, then weekly testing, especially if we get the point of care testing, that will definitely help to screen, so that even if you are asymptomatic, you can get diagnosed and be off the duty hours. Second thing, I also got a question on how long to isolate in home isolation for mild cases. Generally, the period is about 17 days from the onset of symptoms, or if the symptom was not there and patient was asymptomatic from the day of testing, and 10 days of fever, last 10 days fever is not there. Earlier they said we do a repeat test and then discharge the patient when he was admitted, but now repeat testing is not recommended.
Thank you so much, sir. Vinay sir, I hope you are available now. And this is something many of us have been waiting to ask you. Dr. Vinay Shekhar, just sir, yeah. It's an open question. We just want to hear your experience at Gandhi Hospital over the past few months. If you could tell us your thoughts.
Hello.
Yes, sir.
Yeah. No, actually, I'm very sorry because I had some call where need to attend. That's what, but no, I should thank other panelists who have covered wonderfully the other slides. Basically, the hello.
Yes, sir. Please go ahead, sir. Sir, we wanted to know how you are able to manage with the staff, with the infrastructure available at Gandhi Hospital. What do you see are the major challenges now? And more importantly, what do you think from your perspective will be the situation in the next month?
See, in the Gandhi Hospital, we've been working since 3.5 months with, we are wonderfully managing most of the cases, because right now the Gandhi Hospital has been designated as a COVID hospital, wherein we have a lot of positive patients coming here with, and we have started a triage area wherein we are admitting only symptomatic patients and mild cases, as discussed earlier. These have been done with the counseling and sent back home for the home isolation. And people who don't have that facility, because some of the patients are coming from distant places where they don't have facility for the home isolation, we are sending them to the institutional quarantine, where there are some designated places where they have been kept for the 14 days and then sent back. That is one thing. And second thing, nowadays, since 2 to 3 weeks, we have been admitting only the symptomatic patients here. And what I'm observing, we have organized the areas into the 3 areas, wherein we have around 3 ICUs. Here there is a 165 bedded ICU, and in the 3rd floor, and there is one more in the ground floor, that is a casualty, that is a triage area. And third thing, we have one more ICU in the our old AMC, where we are putting all these patients. And apart from this, we have wards wherein approximately each ward 200 to 200, around 150 to 200 patients will be accommodated, which they are once these patients are improving, we are shifting to the intermediate IMC, wherein the patient need oxygen support, and from there, if they recover, they're going to shift to the ward. That is what we are doing. And as far as the healthcare system is concerned, because of the we are being dividing into the groups, probably 2 groups, and one group will be continuing working for about 5 days and taking the 5 days off from the work. That's how we are managing here.
Thank you so much, sir, and respect for the immense work that you're all doing.
Thank you.
Nothing and none of us are in the position that you are all in, and very grateful for the teamwork at Gandhi Hospital. Couple of other questions. I now request Dr. Srinivas to please answer them. Sir, I'll put them across to you. First is role of vitamin D.
Hello.
Vitamin D has, for quite some time has been linked to cell-mediated immunity as well as the cytokine modulation. Even it was postulated that vitamin D deficiency could be the cause why tuberculosis is more common in the deficient populations of Southeast Asia. Now there seems to be a school of thought that the immunological changes that happen during severe COVID or transition of moderate COVID to severe COVID is a combination of derangement of both humoral as well as cell-mediated immunity. So if there is any scope for vitamin D, and we can never write it off because it's an integral part of the cholesterol metabolism, and there are several immune-mediated pathways. So unless there is evidence against, I think and 80% of the population, if you screen them, they would be mild to moderate vitamin D deficient in India. So maybe it's not a wrong inclusion in your treatment prescription. So,
and probably it's the anti-inflammatory effect of vitamin D that is working in these cases. Sir, does fever reduce SpO2 reading?
No, see, it correlates in the sense that the SpO2 falls when the fever spikes, but that doesn't mean the fever is causing the fall in SpO2. The SpO2 is falling because there is a cytokine storm. The cytokine storm is causing the alveolo-capillary derangement that is actually, and it could also be triggering the microvascular phenomenon. So if the fever spikes and the saturation falls, this is a correlation. This is a sequence of events, or the beginning of a sequence of events, which is actually ending up with the florid cytokine storm.
Yeah, Dr. Srinivas, this was a question we faced last month, a month back, where we started seeing patients who have been posted, let's say, for a appendectomy or have come for some other purpose. And then you find that CT chest shows a lot of features. We know that in viral pneumonias, yes, there is a discordance between the clinical picture and the X-ray or the actual CT findings. But how do we explain such florid picture on CT and hardly any symptoms?
Yeah, that is the truth of COVID, in the sense that you could have absolutely horrible looking CT scan and a smiling sitting patient, and you could have a relatively easy CT, a relatively clean CT, and a very badly hypoxemic patient. This is the truth of COVID, what severe COVID, what we are seeing. So there may be several explanations for this. In that the immune response, as described by the cytokine storm, did not happen in this patient, but the alveolar shadowing, the alveolar infiltration has happened, but it did not result in much of gradient or shunt at the alveolar level. This is typical of younger patients. You don't get this kind of picture in the elderly, you don't get this kind of picture in the diabetics, and you don't get this kind of pictures in the CKD patients. You get this in the younger population. The 35, 36-year-old fit young people usually are getting this kind of picture where the CT is scary, but the patient is absolutely happy.
Thank you, sir. Dr. Rakesh, if we can have you back, just two questions. One is retesting. Two scenarios. One, if the person is positive, when do you test again? Second, if the person is negative, but I strongly feel it's COVID, then what do we do? The second question, these two are the parts of the first question for retesting. The next question is, which category of patients would you write HRCT? Is it that all the mild cases will need it? Because just now we've heard how the truth of COVID is that there's a huge discordance, much more than what textbooks tell us. So when do you really write HRCT? And importantly, does it have a value in terms of a management? Is it a prognostic indicator as well?
Right. So I think both important questions are important. Regarding retesting, for routine management of cases, mild to moderate, these patients does not require retesting as such. So they have to be, once the symptom starts, by 10th day, or they are asymptomatic without fever for 3 days, and they can be discharged home with an additional 1 week of quarantine at home with taking all precautions. So they are told specifically that they have to wear mask, they have to do a hand hygiene, they have to follow the cough etiquettes, and all those precautions needs to be done. So the repeat testing is not desirable as a routine in these group of patients. The reason I already discussed with you, because even the dead antigen or the non-viable virus in the body will test positive because of a degraded antigen present in the body at various surfaces, and they will have positive. In specific group of cohort like cancer patients, those who are immunocompromised, like chronic renal failure patients, those patients who are on chemotherapy. So these are the group of patients who would require a negative testing, which is usually done around 13 to 14 days, and then they may be repeated, and then they can be discharged. So this is how we do for the repeat testing. But routine, I just repeat it once again, the routine repeat of RT-PCR is not desirable as of now because of the reasons picking up of the non-viable or non-infectious virions as the positive. With regards to HRCT, I think HRCT is not the diagnostic tool. As our previous speaker also mentioned, there is a lot of discordance between the clinical manifestation and the HRCT findings. HRCT would be totally white out. You cannot see the lungs on it, but the patient may be looking good. So that needs to be taken care of. So HRCT is not the routine management strategies. At our place, we are not doing it very routinely. Only in cases where we are not able to look for the underlying etiology, we are looking whether it's basically in additional some other underlying phenomena has happened, like say pneumomediastinum or something like this, or there's some collection of something somewhere in the lungs. Those are the situations where the HRCT may be desirable to look for that why this patient is not responding. But we should remember, shifting a patient for HRCT from an intensive care unit to a CT room is really Herculean task because of so many reasons. The patient can, during the transfer, the same care cannot be provided to this patient. The chances of infections are very high. So those will be group of patients that will be a little unsafe to shift them. So probably, and our management is not going to change much. With regards to the mild patients, they do not require any imaging access. So there is no indication for HRCT in these patients. there was a couple of document in somewhere in the literature that the CT may pick up the diagnosis of COVID with the signs prior to the RT-PCR positive, but that has been defined once again. So HRCT is not the screening or the diagnostic tool for diagnosing the COVID-19 patients.
Thank you, sir. A couple of other questions we've covered them in the presentation, so some of them I have no option but to discuss lack of time.
Sure.
Newer anticoagulants, I think we've covered it. Role of plasma therapy, we have already covered that part. And newer anticoagulants and others. Question on LDH and ferritin. Dr. Rakesh, final word. LDH, ferritin, are they part of prognosis? And I was looking for this evidence but didn't find. Many of these disorders where there is a progression from one stage to another, we often have a score. And this score is able to determine which parameter is worsening, and we are able to quickly make a decision. Do we have any scoring system like this?
So we do not have a scoring system. I remember there are 2 scoring systems which has come into picture, which has involved various clinical parameters. But the COVID is, the new things are coming up so routinely that even somebody has made it, it will not be very useful subsequently because the things have changed. We started in sepsis induced areas, we have come to a different picture of areas, management is almost different. Even we have also prepared the scoring system for the diagnostic modalities for screening these patients with COVID-19. And I'm sure it will be published by next week or so. But this is primarily a screening tool wherein we have used multiple parameters from the meta-analysis of the already published data. With regards to the ferritin, ferritin is primarily a prognostic indicator that indicates that how much body inflammatory response is happening. So the increasing trend shows that probably the patient is shifting from mild to moderate and moderate to severe category, and primarily from moderate to severe category. So that would be the prognosticating modality. I will not say actually prognosticating, but that is, you can say, the change in the severity of the patients by mounting the inflammatory response inside the body. So increasing level of ferritin will be an indicator, and same will be for the LDH also, that yes, the patient is mounting a huge response, and that's why the patient can land up into subsequent some amount of respiratory compromise, because the ARDS type of phenomena will be happening in the lungs, and that's where patient can deteriorate. And that can help us to take decision that this patient requires intensive monitoring and needs to be shifted to ICU.
Thank you, sir. Now, next question, last set of questions. Dr. Srinivas, this question is for you on the pre-operative protocol. At your hospital, what is the protocol? And also for smaller nursing homes, and we're talking about the entire state of Telangana, right from the district level. When you don't know the status, when we are not testing everyone, at the same time, there's an operation or a procedure to be done. What do you advise, one, at your hospital, secondly, for the rest of the state as well?
Yeah, that's a difficult question to answer. It also depends upon how comfortable the anesthesia team is in taking a positive patient for a general anesthesia, which requires endotracheal intubation and consequent. But if there's an emergency, for example, a ruptured appendix, for example, or a cesarean, for example, or a head injury, a subdural or an extradural, for example, there's no way we can deny surgery for that patient just because we are suspecting COVID, right? So the bottom line is you treat every patient in the current time of pandemic as suspect, and you take all your precautions. You wear your PPEs, you wear your masks, you wear your respirators, and do the patient. But sometimes if the patient gives you time for imaging, maybe if you think if the patient has been absolutely asymptomatic, we still go ahead with the emergency surgery as with all precautions. But there have been vague symptoms. We are actually doing CTs for these patients to see if there is any ground glass opacification. And if there is ground glass opacification in the absence of symptoms, we are following all the precautions for surgery. Those who are coming for elective surgery, in fact, the obstetric patients, there is a recommendation that all the obstetric patients who are coming to the antenatal clinic should be screened by PCR at least 5 days prior to their expected date of delivery, so that you know what is their status. They may end up with a cesarean, they may not end up with a cesarean, but for that subset of patients, there is a recommendation. So if the patient is coming for elective surgeries, we are actually seeing the background, seeing the family history, seeing if somebody has been symptomatic, Has this patient come from a containment cluster, or the family member has had some symptoms? If they are there, we are asking them, we are actually using the PCR to screen these patients. But for the rest of the state, this is not going to be a practical solution. So it all depends upon the good history taking, going back into the antecedents of the patient, looking at the symptoms and the gravity of the surgery that is needed, taking all precautions, and then going ahead with the surgery.
Thank you so much, Dr. Srinivas. Now, closing remarks, I'll request Dr. Vinay Sekar, sir. Sir, as we see close to 1,000 cases every day being reported, and many of us feel the number is much more, it's just that it's not on paper. Is there some set of advice which you would like to give to all the IMA members who are probably seeing these asymptomatic or pre-symptomatic, as well as, I would say, adult and children with COVID-like symptoms? Any specific advice you would like to give to all the IMA members?
Sir, as you said, the basic thing is we have large number of patients with mild symptoms, where we have a lot of doubt whether we can keep it home or not. But what I have seen here, patients who have no comorbidities and who don't have especially the end organ damage like CVA, cardiovascular disease, CKD and all these patients, if they don't have all these more comorbidities and younger age, and people have mild symptoms, definitely can be kept at home and with a strict all precautions to be taken care at home. That is what is important. And second thing, as I said, happy hypoxia, people who are little tachypneic, they seem to be very comfortable, but still they have hypoxia. Such patients, definitely they need to be monitored in the hospital, and most of them are also recovering once they settle down.
Thank you, sir. On behalf of the entire team at IMA as well as UNICEF, extremely grateful for your efforts at Gandhi Hospital, and thank you so much, and look forward to much better times, and nothing can replace the huge amount of commitment efforts from the entire team at Gandhi Hospital. Please convey our regards and best wishes to the team. Last remarks from Dr. Rakesh. Dr. Rakesh, this question we've been asked repeatedly. As this disease evolves and we get more information, we have seen guidelines change. Initially, only the sick to wear mask. Now everybody wears a mask. Initially, no point of care testing. Now point of care testing can be done. So as this evolves, let's say in the next 1 or 2 months, what is it that is expected from the point of view of diagnosis, especially for testing? And is there a way out in the monsoon where we expect that we see more of dengue, more of seasonal illnesses? What are your thoughts? Dr. Rakesh, if you're around, if you could unmute yourself, please. I think we seem to have lost Dr. Rakesh. Final comments from Dr. Srirang and Dr. Srinivas before I can close. Dr. Srirang first, please.
Yeah. There was this question you asked, like initial testing is negative, but you strongly suspect a person to be COVID positive. Do we do a testing again? In our clinical practice also, we found patients have tested themselves very early, maybe day 1, day 2. They still have all the manifestations, including the CT features, and that negative test sometimes makes them really come off their precautions. But we've repeat tested them, and then they have found to be positive. So it is important that if you have a strong clinical suspicion, despite the initial test, you do a repeat testing and then confirm the disease. And as a take-home message for all mild cases, clinical monitoring is very important. Strict isolation precautions are there, supplements are there, and there's also this question who asked, if you have given a report and report is still awaited, what do we treat the patient with? You can treat him symptomatically for his respiratory tract infection, and if he has comorbidities with the ECG monitoring, even before the report comes, you can give him hydroxychloroquine.
Thank you so much, sir. Last comments, Dr. Srinivas.
Yeah, thank you, sir. I can only say that this disease has reiterated the basic principles of medicine. Uh, princ- Prevention is always better than cure, right? And sticking to your basics will always win the match for you. So, and the healthcare facilities, whatever we have enough, we may have enough, we may not have enough. How judiciously we use our healthcare resources is a responsibility all of us should have. And my request to the IMA is to actually take this message to the community that if you are mildly symptomatic, or if you only have a fever, it is easily manageable at home with due precautions, and having a doctor on call is probably the best way. The healthcare infrastructure in any country, the best of healthcare setup. Germany has the best infrastructure. Italy had the second best healthcare infrastructure in the world. They struggled. So every healthcare system is creaking under the weight of COVID. So I think what we should try to do is, rather than get into the hospital just for isolation or just for the chloroquine dose, we should probably try to get a message across to the community that let the sicker patients be in the hospital. The less sicker ones can be taken care of under proper guidance on phone or on teleconsults by physicians or pulmonologists at home. Because this is what will keep the beds available for the needy, for the hypoxic patients, those with high risk factors, and those who need immediate attention. This is my request to the IMA.
Thank you so much, Dr. Srinivas, and heartfelt thanks to all the panelists working in Virinchi Hospital, in Uday Omni, two very big corporate hospitals of the city, apart from Gandhi Hospital, which is the hub of all the action, and of course, All India Institute of Medical Sciences. 2 hours of your precious time for the IMA Hyderabad City chapter and UNICEF. Thank you so much for your time and efforts. I still have questions coming up, but I don't think I will be able to extend any more. But we'll be happy to answer any more queries. Please pass them on to Dr. B.N. Reddy, and we'll be happy to take over. I now hand over to Dr. Reddy. That's the close of the session, sir.
Yeah, thank you, Dr. Sri Krishna and your UNICEF team for organizing this webinar for us. And I thank all the panelists, Dr. Rakesh Garg and Dr. Vinay Shekhar, Dr. Srinivas, Dr. Sriran for their excellent information they have given to us. Thank you very much. Thank you. Yeah.
Yes.
Thank you.
Yes.
Thank you very much.
Yes, sir. If there are anybody else who has any remarks, let me know when we can end the meeting. Yes, sir. Please go ahead, sir. Any of the senior IMA members as well, if they would like to say a few words, we'll be able to close by 5 sharp. Srinivasan sir, may the voice clear ga ledu. You'll have to keep the mobile or the laptop closer.
If there are any queries left, I represent to send these queries to our mail, IMA Hyderabad City mail, so that the answers, they will get the answers.
Yeah, if Dr. Mohan Gupta is there, any comments from Dr. Mohan Gupta? Hello, sir.
He was there in the panel. Let me see if I can add him back here. No, sir, I can't find Dr. Mohan Gupta.
Yeah, maybe yes.
Get ready, sir. Okavela ayana baita unte okasari you can get him to the panel, or you can allow people outside as well. You also can unmute and then allow them to come.
Okay, yeah, I should thank the UNICEF people for organizing this. Is a wonderful exposition, and I think a lot of us have got benefited with this. We thank all the panelists there who have attended this, and especially Sriran from our Uday Omni Hospital, who has taken pains to present this today's, and also congratulate the office bearers of IMA Hyd CIty Branch to organize this. Thank you.
Yeah, thank you. Thank you, Urlam. Here is the meeting. And Personal thanks to Dr. Sri Krishna.
BN Reddy sir, once you announce, you can end the meeting at your level as well.
Yeah, thank you. Thank you, Dr. Sri Krishna. We'll end. Okay.
Yes.
Okay.